Welcome to the conference session titled Transplantation for Severe Aplastic Anemia. Thank you for joining us. My name is Derek Amana, and I am the marketing coordinator, and I will be moderating the presentation today. As we get started, we recognize the generosity of the corporate sponsors and the generous support of patients, families, and caregivers for supporting the conference today. Immediately following the presentation, there will be a question and answer session. If you are participating online, please feel free to submit questions at any time during the presentation from the Q&A icon in the engagement panel on your right. To submit a question or comment, type your question in the Q&A text box window, and when you have finished typing your question, hit enter. We will do our best to get all of your questions. When asking questions, I respectfully ask you to do two things to help me manage the incoming questions. First, submit your entire question all at the same time. Second, please do not share private health information in your question. Our speakers cannot answer any specific questions related to your healthcare. Today's specialist is Akshay Sharma. Dr. Sharma is a bone marrow transplant physician at St. Jude Children's Research Hospital, specializing in transplant and gene therapy for non-malignant hematological disorders. He earned his MBBS at Kasturba Medical College, Manipal University, Mangalore, India, a postdoctoral fellowship at Emory University, Winship Cancer Center, Atlanta, Georgia, his residency at University of Kentucky, Lexington, Kentucky, and clinical fellowship at St. Jude Children's Research Hospital, Memphis, Tennessee. His research interests include gene therapy and gene editing, bone marrow transplantation for patients with non-malignant hematological conditions, development of novel reduced intensity and non-myeloablative conditioning regimens. With that said, welcome, Dr. Sharma.
Thank you, Derek. I know that was a mouthful for you. So I am really honored and privileged to be here today. And thank you to AAMDS and University of Tennessee and Dr. Thota for inviting me to give this talk. So as Derek said, I'm a pediatric bone marrow transplant physician, and I specialize in non-malignant hematological disorders. So this topic is very near and dear to my heart. So as many of you probably know, we have in our long bones these tiny holes or spaces in which hematopoietic stem cells live. And these hematopoietic stem cells are these maverick cells which have the capability to produce their kind for the rest of their life. But then also, these hematopoietic stem cells give rise to every other type of blood cell in the body. So they give rise to your red blood cells, to white blood cells, to platelets, to lymphocytes. Every blood cell that is circulating in the body right now comes from these hematopoietic stem cells. And so when these hematopoietic stem cells are functioning normally, they produce all these blood cells for the rest of your life, and you have normal blood counts. But unfortunately, when sometimes something goes wrong with these hematopoietic stem cells, it results in what we call bone marrow failure, which aplastic anemia is a type of. And so over the next couple of slides, I'll give a very brief introduction of aplastic anemia. I believe some of the previous speakers might have covered that already. But again, I think some repetition is good. So I'll cover that very briefly, and then we'll move on to what the treatments for aplastic anemia are. And so, like I said, bone marrow failure, it can be of two broad categories. So it can be caused due to inherited syndromes, which are usually genetic in reason, and they're not the majority. About 30% of all bone marrow failure is caused due to inherited syndromes. The vast majority, though, is acquired. It happens after an individual is born, and it's usually not genetic in origin. And the most likely cause is aplastic anemia. And so aplastic anemia, like we were talking, is a disorder of the hematopoietic stem cell, the factory that makes blood cells. And it is characterized by a deficiency, a reduced number of these stem cells in the bone marrow. It's quite rare in the Western countries, with the incidence being about 2 per million people. It's a little bit more common in Asia, where it is about 4 to 6 million per million. And it's generally seen in 2 age peaks. So generally teenagers and adolescents between 15 to 25, or then older adults over 60 are the ones where we tend to see it. And there is usually no gender difference between males and females in aplastic anemia. It's characterized by low blood cell count. So your bone marrow doesn't work, the cells are not making blood cells, so you don't have blood cells in your blood. And these people generally require a lot of blood transfusions, whether platelets or red blood cells. Also, when you don't have neutrophils, a type of blood cell which helps fight infections, individuals with aplastic anemia are at high risk of developing infections as well. And when people don't have platelets, they are at a high risk of developing bleeding problems. And so the diagnostic workup for aplastic anemia generally comprises of doing some blood work and doing a bone marrow biopsy. So when we do the blood counts, we see that individuals with aplastic anemia have decreased blood counts in almost all types of blood cells. So they're neutrophils, platelets, red blood cells. And then when we do the bone marrow evaluation, basically when we put a needle into the bone, take a little piece of it out, on the right side, you can see that on top, the normal marrow has a lot of cells in it. All these blue dots are blood-forming cells. But in an aplastic marrow, in an individual with aplastic anemia, their marrow is almost empty. And as you can see, there are hardly any blood cells over there. So if an individual has at least 2 blood cell lines down and bone marrow cellularity less than 25%, they are diagnosed as aplastic anemia. In addition to that, we also generally do some genetic tests looking at telomere lengths and chromosome breakage studies, etc., vitamin levels, to figure out if there are other reasons for an individual, sometimes genetic, to develop bone marrow failure. So, like I said earlier, the vast majority of aplastic anemia is idiopathic, and that's just a fancy way of saying that we physicians don't know what caused it. So, unfortunately, despite all the research that has happened, for the vast majority of patients who develop aplastic anemia, we really don't know what caused it. But in some small minority of patients, we can find either viruses like hepatitis viruses, Epstein-Barr virus, cytomegalovirus, etc., which have caused aplastic anemia. Again, in small number of individuals, it's either exposure to certain medicines or toxins, or it could be also due to immune disorders, which could cause aplastic anemia. So, like when we were talking about the pathophysiology, what causes aplastic anemia? So, what is the baseline pathology? So, in aplastic anemia, the baseline pathology is a problem caused by these T lymphocytes. So, lymphocytes are cells in our body which are meant to fight infections. Their job is to fight anything that doesn't look like our body. But sometimes these lymphocytes, they go awry. And when they go awry, they fail to understand that their own cells are getting attacked. And so if these lymphocytes start attacking the blood stem cells, of course, the stem cells disappear. And if the stem cells disappear, there will be no blood production, and that leads to aplastic anemia. So in short, it's usually a dysregulation of these lymphocytes, which could be caused because of a number of reasons that we talked about in the previous slide. And so once we have made a diagnosis of aplastic anemia, if the patient is younger, and I've put the age 40 over there in inverted commas because this is sort of a moving target. Previously, we used to say anybody less than 20 was young. Now we say 30 is young. Today, 40 is also the new youngish. Maybe in some time 50 will be young, or even 60. I mean, I think it's a state of mind, right? And so younger individuals and those who have a HLA matched sibling, and HLA matched sibling is basically a brother or sister who's a full genetic match to you. If you have a person like that, you could get a matched sibling donor transplant. If you don't have a sibling donor, or if you're older, generally you would get immunosuppressive therapy. And if immunosuppressive therapy does not work, then we would look for a donor in a registry and try to find a suitable donor for you. So let's first briefly talk about immunosuppressive therapy and how it's done and what does it mean. And so immunosuppressive therapy is exactly what it says. In immunosuppressive therapy, we use medicines to suppress the immune system. And so remember that T cell, which was killing the blood cell, we try to give medicines to get rid of that T cell. We suppress that T cell. And so there are two common medicines, ATG and cyclosporin A. These are very commonly used medicines for immunosuppressive therapy. Other drugs like MMF, cyclophosphamide, alemtuzumab have also been used, though they are not as effective. And like I said, usually immunosuppressive therapy is reserved for older individuals and children who do not have a full sibling donor, or other individuals who are otherwise not eligible for transplantation. I should mention, though, that immunosuppressive therapy is not an immediate cure for everybody. It takes a long time to give immunosuppressive therapy, sometimes to the order of months to years. And there's always a risk of relapse in individuals when they get immunosuppressive therapy. Their aplastic anemia could come back. So in this slide, I'm showing a number of studies that have been done over the last several decades in different countries. And while I don't want you to focus on the details of each one of these studies, I've highlighted a couple of columns over there. And so if you look at the response and the relapse column, you will see that in all of these studies, there is an upper limit to how many patients actually end up getting a response. So with immunosuppressive therapy, we can help about 6 to 7 out of 10 patients. The remaining 3 to 4 out of 10 patients do not have any response to immunosuppressive therapy. And then even those who have a response, about 10 to 40% individuals, they relapse. So their disease tends to come back after you get rid of immunosuppressive therapy. And then when you look at the last column on this slide over here showing MDS or leukemia, there is a risk that some individuals with aplastic anemia could develop leukemia. And that risk does not go away when we use immunosuppressive therapy. So about 5 to 10% individuals, so they could progress to having a clonal proliferation, developing MDS or leukemia, despite getting immunosuppressive therapy. When people have tried to intensify immunosuppressive therapy, so like I told you that the most common immunosuppressive therapy is ATG and cyclosporin A. Individuals have actually tried to add other drugs to it. So they've tried to add sirolimus, they've tried to use alemtuzumab. And even with that, as you can see, the response remains about 50 to 60%. And there is still about 10 to 40% risk of relapse despite immunosuppressive therapy. And again, when you look at the last column over there, there is about that 10% risk that some of these individuals could proceed to developing MDS or leukemia. So there really isn't a golden bullet here with immunosuppressive therapy. Recently, eltrombopag, this is a new agent that has been developed. It's a medicine which actually increases the number and quality of the hematopoietic stem cells and actually causes more production of certain types of blood cells. So when that has been combined with immunosuppressive therapy, some individuals have actually had a good response quite early. But when immunosuppressive therapy or eltrombopag has been withdrawn, they tend to lose that response. So I really like this picture that was published in a paper that talked about eltrombopag. So they show that there is this kid and aplastic anemia is like a fire. And so when they use eltrombopag, this kid gets a jump start. And so he jumps, he has a very early response. But when you get rid of either eltrombopag or IST, they end up relapsing. Now, so they fall into this cliff over here. But then many of these individuals we can actually rescue. So we can use a second line of immunosuppressive therapy, and then they get better. But there is always that 40% risk of relapse and about 15% risk of clonal evolution that can happen in these individuals. Another study which was done and published quite recently, which looked at eltrombopag use in children, compared it to a historical cohort of immunosuppressive therapy recipients. And what they found was that in children who use eltrombopag, the risk of relapse was actually quite high. Now, I understand there were just 40 children being compared to another 87 in the control group. So it's not a very big study, but at least it gives us a hint that eltrombopag, again, is not a magic bullet that we were hoping it would be. And so to summarize what I just talked about immunosuppressive therapy, it comes with an infection risk because we are suppressing the immune system. So for 6 to 9 months, when individuals are getting it, they remain at a high risk of catching infections. Cyclosporin, one of the more common medicines that we use, is associated with a lot of other side effects. Children and adults tend to develop a lot of hair, which is especially distressing for girls and women. Cyclosporin can cause Kidney injury, in some individuals, it can also cause really bad gum hypertrophy. I've actually seen individuals that their teeth completely disappear. They are swallowed within the gums. It's really bad, and the gums bleed, and we have to stop cyclosporin. ATG, it's an antibody which is produced from either horses or rabbits. And so individuals who get it can have an allergic reaction. They can develop hypertension. And like I said earlier, it takes a very long time. It can take months to years for us to see a response from immunosuppressive therapy. And as I've said multiple times, there's always that risk of either developing MDS or leukemia or a risk of relapse. And so now let's talk about mass sibling donor transplant. So I'll try and contrast what I just told you about immunosuppressive therapy with transplant to see where the differences and similarities are. And so bone marrow transplant, the whole idea is to replace the bone marrow stem cells. So we know that in aplastic anemia, the bone marrow stem cells are getting killed by these T cells. So the idea of transplant is we kill the T cells, and there is empty marrow left behind. Let's fill that empty marrow up with stem cells from somebody else. And it's better if we find that somebody else who is genetically as similar to you as possible. And so it's preferred for younger patients. Children do very well with transplant. Again, one of the problems is that you have to have a donor. So you either have a matched sibling, or you have a donor who is in the registry who has volunteered that if somebody out there needs a transplant, out of the generosity of their heart, they say, I'm going to be their donor. And comparing it to IST, to immunosuppressive therapy, transplant is indeed a cure. It's a one-time treatment, and those individuals who get a transplant and it's successful, they are cured forever. There's usually no risk of relapse afterwards, and there is absolutely no risk of clonal evolution or developing leukemia after that. But I have to mention that transplant definitely carries a lot more risk than immunosuppressive therapy. So before I go forward, let me just briefly talk about how do you do transplant, because immunosuppressive therapy, I think most people understand, these are medicines that you have to take either by mouth or by an IV. And we all have taken medicines at some point in our life, so it's the same. But transplant is different. So let's say there is a patient with aplastic anemia, they're getting a blood transfusion, and this is what their blood looks like. As you can see, there are very few blood cells over there. So the first thing that we do is to find a donor who is as close of a genetic match to this recipient. And then we collect stem cells from this donor. There are various ways to collect stem cells from donors. Then we give the recipient some conditioning regimen. It's usually chemotherapy, which is given to wipe out any of those bad T cells which are causing aplastic anemia. And then we put these stem cells from the donor into the patient and wait for a few weeks. And as we wait, these stem cells, they grow in the recipient. And as they grow, they start making new blood cells. And now our aplastic anemia patient does not have aplastic anemia. They're making blood cells just like the donor would be making in their body. And so that sounds very simple, but it's not. It takes a very long time as well. So generally, when we plan to do a bone marrow transplant, we first have to do a thorough evaluation of all the organs of the body. And that can take up to 2 to 3 weeks. We have to look at your heart, your kidneys, your lungs, make sure everything is working fine, that you don't have an active infection going into transplant. Then the donor search and collection of the graft from the donor, that can take anywhere from 2 to 4 months. If we have a brother or a sister who's willing, who's ready to go right next to you, it can be done in as little as 1 month. But if we have to find an unrelated donor in the registry, it could take 4 months or longer. Then we admit the patient in the hospital and we give them chemotherapy to kill these bad T cells and make space in the bone marrow, and then give them the graft like I showed you in the previous cartoon. And that in itself can take up to 5 to 8 weeks, during which you are in the hospital being actively monitored and can't leave and can't go anywhere. And then there is that period of early post-transplant follow-up, during which patients are usually seen in the bone marrow transplant clinic, either at least once a week or sometimes even twice a week. That lasts about 3 months. And then once those acute complications are resolved, we follow patients in a transplant clinic less frequently, sometimes once a month, sometimes once every 6 to 8 weeks. And that goes on for about a year. And then there is that long-term follow-up to follow up for any leftover long-term complications that transplant might have caused. And that follow-up can last many years to decades, and sometimes even lifelong. And so although transplant is a one and done cure, it is one of the more intensive treatments for aplastic anemia and definitely requires a lot of resources and commitment from both the providers, physicians, nurses, respiratory therapists, coordinators, and the patient and family also. And so when we talk about transplants, I've briefly touched upon this also, but you can have a number of different donor choices and you can have a lot of graft choices. So donors can be a family member who can be genetically a full match or genetically not so much of a match. We can have volunteer donors who are registered in the registry, or we can have cord blood donors. And then we can either get bone marrow from them, or we can get peripheral blood-derived stem cells or cord blood again. And if I had to score these different donor choices or graft choices, I would say that an HLA matched family member, if we can get bone marrow graft from them, that would get 3 stars from me. 2 stars would be an unrelated donor who's a full match, or if we get a peripheral blood-derived graft. And the 1 star or the least favorable would be any mismatched donor or cord blood donors. And while I don't have a lot of time to go into the details of this, generally speaking, the risks of transplant are less when the donors are related or a good match, when the graft is being obtained from bone marrow, and the risks of transplant are higher when we are using a mismatched donor or cord blood donor or peripheral blood grafts. And I'll talk about some of these risks, but broadly speaking, the more matched and the bone marrow graft donor we get, the better it is. And so when we look at some of the contemporary recent data about matched donor transplants for aplastic anemia, there was a study done by the CIBMTR at 145 centers all over the world. It included 833 patients. And they found that one of the complications of transplant, chronic graft versus host disease, it occurred in anywhere from about 10 to 20% patients. But the overall survival at 3 years was very good at 90%. So 1 out of 10 individuals would die either because of the complications of their aplastic anemia or because of the complications of transplant during a 3-year follow-up. But the vast majority would do well, and some of them would develop a complication of transplant. In most of the individuals, fertility was preserved, and they really did not have a lot of long-term side effects. A similar study was conducted in Europe by our colleagues who studied children, and they studied about 200 patients. Again, very similar type of transplants for aplastic anemia. In the pediatric cohort, the chronic GVHD was a little bit lower, but still there, about 6 to 20%. And then overall survival at 3 years was equally good, about 90%. So again, when I'm saying, if you were paying attention and remembering some of the numbers that I told you earlier for IST, I told you 60% would respond for the IST and up to 40% could relapse, and there was a 10% risk of leukemia. I didn't tell you any of that. I said 90% is a cure. So why don't we just transplant everybody? You would say, this is Dr. Sharma, you are, this is not making a good argument. You should just transplant everybody. So there are problems. One is that some individuals can have a graft rejection. When we try to put in a transplant, the recipient gets rid of the graft. And so that does happen in a small handful of individuals, about 5 to 10% or less. There are risks of harm. Like I said, we use chemotherapy to do transplant, and these conditioning regimens that use chemotherapy or radiation can be quite intense. They can cause organ damage. So they can damage your heart, they can damage kidneys, lungs, liver, etc. Again, there is a small period of time when you are admitted in the hospital for about 5 to 6 weeks and you don't have an immune system. And so during that time, the risk of infection actually goes higher. Then there is that risk of graft versus host disease, which I will describe a little bit in more detail in the next few slides. But then, of course, there are some long-term side effects. Some individuals could have organ damage, which could last for the rest of their life, and they would have to go and see a physician for getting that managed. And rarely, some individuals could even die because of transplant. And so we can do all the different things to avoid that and make transplant safer, but there still remains a risk of death for some. And so the only thing that I can say about this is that I think these risks are different for different individuals. And for some, they are obviously higher, for some, they are lower. And so every patient needs to talk to their physician about what their risk might be. And then lastly, not everybody has a donor. And so we may not find a suitable donor for everyone. And towards my last slides, I think I'll talk a little bit about what are we doing for patients who may not have a matched donor. So let's talk about these issues that I just mentioned on the previous slide. So graft rejection. So rejection happens when we try to put the graft into a patient and the patient's T cells haven't been completely gotten rid of. And so those T cells come back with a vengeance and they get rid of the graft. So remember, those T cells were killing the stem cells in the patient himself. And now we are trying to put in new stem cells. But if we don't give a very good dose of immunosuppression, if we don't get rid of all those T cells before, those T cells could still be hanging around, lurking. And as soon as we put in the new graft, those T cells come fighting back and get rid of the graft. And so it's not very common with some of the modern techniques. I would say that the risk of graft rejection is less than 1%. But definitely, as you know, aplastic anemia is a disease where the T cells are attacking stem cells. That risk could be higher in some individuals. Again, the risk is higher with individuals who don't have a good match with their donor, with cord blood donors and T-cell depleted transplants. And we do T-cell depleted transplants to reduce GVHD. So to reduce one of the complications of transplant, what we do could actually increase the risk of rejection. And so there has to be that balance that we have to take into account. But then again, like I said earlier, cord blood and mismatched donors aren't my favorite. I gave them 1 star, but I probably shouldn't have given them that either. There are other issues with graft versus host disease. And so graft versus host disease is when the graft is attacking the recipient. So in some ways, it is opposite of graft rejection. And rejection, the recipient was getting rid of the graft. Here, graft is getting angry and attacking the recipient. And graft versus host disease can affect multiple organs. It can affect skin, liver, intestines. And so I'll show you a little bit what it might look like. So this is some representative pictures from a few individuals who have developed skin GVHD. And you can see from, it can just look like a skin rash, which can be extremely itchy. And it can occur on small part of the body or your entire body. Or it could look like ulcerations in the skin, which heal with terrible scarring over time. And of course, this could be very disruptive to some individuals, well, actually to most individuals who experience this severe degree of GVHD. If it affects the liver, it could cause jaundice and sometimes even liver failure. And then if it affects the intestines, it causes severe and profound diarrhea and vomiting. And in some individuals, this diarrhea can be as bad as pooping out 4 to 5 liters of diarrhea in a single day. I've had patients who had to sleep on the commode because they were pooping every 30 minutes. They couldn't get up. And so these can be pretty intense complications. And while with some of the modern techniques, the risk of graft versus host disease has been decreased, we cannot predict which individuals might end up getting it. And if you try to use techniques which reduce GVHD, the risk of rejection goes up. So there is always that balance. How do we manage this? We talked about late effects of transplant a little bit. And one of the big late effects is the exposure to conditioning regimen could cause sterility or inability to have children as patients grow up. Some individuals who have been exposed to chemotherapy can develop cancers later on in their life. And cardiovascular disease or injury to the heart and the blood vessels are also quite common in individuals who have received a transplantation. So transplant outcomes have improved over time, and early referral has been the most important and single most significant factor that helps improve survival. And so individuals who as soon as they're diagnosed with aplastic anemia, if we know that they are going to go to transplant, just get referred to transplant and get a transplant in less than 6 months or less than 3 months after being diagnosed, have the best outcomes. Those individuals who have gone on through multiple cycles of immunosuppressive therapy, not responded to them, waited for a few years and then gone to transplant, tend to have worse outcomes than those who go in early. Again, I've said this thing many times, but better matched donors are, again, very important to get a good outcome after transplant. And so expansion of donor registries. Now, current donor registries, about 15 to 20 million people enrolled in them. Volunteers such as you and I, who have volunteered that, if somebody needs a transplant, I'll give my bone marrow to them. And so I would encourage everybody to go and register for your NMDP or Be the Match registry, so that if somebody needs a transplant, maybe you are there for them. Reduced toxicity conditioning. There are improved methods where we don't use as much chemotherapy anymore, and those have improved both graft versus and improved graft versus host disease prevention regimens have also decreased the risk of GVHD. And then lastly, as we have learned more about infections, we've actually developed better methods for monitoring infections and also for treating these infections. And so people often ask me, knowing what I know now, is one therapy better than others? IST the best treatment? Should everybody get a transplant upfront? What I answer is, it depends. IST is generally milder than transplant in intensity, and if it works, one can totally avoid transplant and associated toxicity. But transplant is definitely a one and done approach. You don't have to go through a months-long immunosuppressive therapy. At the same time, there are short and long-term toxicities of transplant, which can be severe and sometimes life-threatening, honestly. But there is a high risk of failure of IST and relapse, and afterwards, many patients have to go through transplant anyway. And so I think what I've tried to convey to you over the last few minutes is that there is no right answer right now. We don't know if IST is definitely better than transplant, although many of my colleagues do have very strong opinions about it. But I think it's an individual choice, a decision that needs to be made by all patients in collaboration with their physicians. So if you have aplastic anemia or you have a family member who has aplastic anemia, I would encourage you to have that frank discussion with your physician up front and consider all these options. So because there is this equipoise, because we don't know whether IST is really better than transplant or not, or is transplant better than IST, there is an ongoing study called Transit. This study is currently comparing transplant to immunosuppressive therapy, upfront transplant to immunosuppressive therapy, and a phase 3 study, which will randomize patients to get one or the other to compare these two outcomes will soon begin. And so hopefully, once this study concludes, I will be able to stand here and tell you conclusively that yes, one of these therapies is definitely better than the other, and everybody should get that. But until then, like I said, I think talking to your physician is the best approach. So I mentioned many times, and I think I've broken that record already, by saying that a matched donor is the best donor. So that's the kind of donor. So if that's the only thing that I conveyed in this talk, I think that's enough. But what about those who don't have a matched donor? And a number of individuals actually don't have a matched donor. Well, they may not have a fully matched donor, but they may have a half matched donor. And half matched donors are called haploidentical donors. So almost everybody has one, if not more, half matched donors. For children, their parents are always a half match. So because we get half of our genes from our mother and half our genes from our father, our parents are always half a match for us. And likewise, our children are always a half match for those of you who have children. Your children are half a match to you. So there is always, if you have parents or siblings around, there can always be a donor for you. Again, we could also look at your brothers and sisters or cousins or first degree relatives, and some of them may also be half matches. And so half match donors are available, although the risk of graft rejection and graft versus host disease is higher when we use half match donors. But for somebody who doesn't have any other donor choice available, half match donors could be a lifesaver. I actually have a patient that I'm taking care of right now who is 22 years old and was diagnosed when she was 16. So she has had aplastic anemia for over 6 years. And she was just living on blood transfusions and was having terrible complications because of that. And so she did not have any donors. Her only donor was her younger brother, who was only a half match. So she came to us and we did a half match transplant, and She's now 4 months out of transplant, doing quite well. And believe it or not, she has so much energy now. Her hemoglobin used to be 6 or 7 before she got transplant. Her hemoglobin right now is 14. And she has so much energy and doing well. But she's not out of the risk window. She's just 4 months out. She could still have complications because of the half match transplant. So we're still going to continue to monitor her. But what I wanted to convey is that there is an option for individuals who don't have a full donor. And so there are multiple half-match transplant approaches that are being developed. Many of those are in clinical trials. So one of these approaches to use a full bone marrow transplant followed by post-transplant cyclophosphamide. So by using this approach, the overall survival is about 80%. So I told you with a fully matched donor previously, the survival is about 90%. Here it's a little bit lower. And the risk of graft rejection with a fully matched donor was less than 10%. Here it's about 15%. And as you can see in the last line, the risk of GVHD is about the same. So, so there is this newer method, well, not as new anymore. Post-transplant cyclophosphamide has been around, but there is this method of doing transplant for aplastic anemia, which is being used by a number of centers in some clinical trials. There is a trial called CHAMP trial, BMT CTN 1502, which recently concluded, and we are awaiting results. But there is this method of doing a transplant. There is another method where we actually don't give that much chemotherapy. We take the cells, we filter them out, we remove the bad cells from the graft and only give the good cells. That's called the TCR alpha beta depletion approach. And again, the results are quite similar, 80% overall survival, 10 to 15% risk of graft rejection, and a little bit higher risk of GVHD. So there are these newer methods of doing half-match transplants, which we are making better as time goes by. And hopefully in the next 5 to 10 years, we could improve the efficacy of these half-match transplants and make them as good as a fully matched transplant. And so to conclude, there are several treatment options for aplastic anemia. I've talked about immunosuppressive therapy. I've talked about L-thrombobag, matched sibling donor transplants, half-match transplants. Immunosuppressive therapy is a good treatment for those who don't have a fully matched donor. And then transplant outcomes are improving for patients with aplastic anemia. Matched sibling donor would be my first choice. If somebody doesn't have a matched sibling donor, a matched unrelated donor from the registry would be a fairly closed second choice. And then for haploidentical half-match transplants, clinical trials are ongoing. And we are hoping that these half-match transplants will be able to provide a donor for everybody. And so with that, I will stop and I will take any questions. Thank you very much for your attention. If I'm not able to ask any questions right now, you can reach me at my email at akshay.sharma@stjude.org. Or I tweet about aplastic anemia and transplants on Twitter at Akshay Sharma MD, so you can follow me and learn more about that. And like Derek said earlier, although I am a doctor, I'm not your doctor, so I can't provide medical advice for your particular situation. So please don't share any personal health information with me. But if you have general questions about transplants or aplastic anemia, I'm certainly more than happy to answer. Thank you very much.
Thank you, Dr. Sharma. So I want to open the floor up for anybody in here. Yes.
I know each facility is different on how they define successful transplant. What is y'all's facility, the definition on successful transplant?
Yeah, so the question is, what does successful transplant mean? And every person defines success differently. And I would say, I personally and our facility, St. Jude, we don't have a definition of success because it really depends on who we are treating and what the patient is, right? And so, for example, I told you about this young woman who we are treating right now, and she had received a number of different immunosuppressive therapies over the last 6 years, and her aplastic anemia just never went away. Actually, Dr. Thota helped me take care of that patient, and so she was needing blood transfusions for the last 6 years, every week, every couple of weeks. And as you can imagine, you can't live with blood transfusions like that for the rest of your life. So for her, nothing else was working. And if we had not done the transplant, unfortunately, she would have passed with the complications of the blood transfusions or complications of her aplastic anemia. And so I think for her, where she is right now, having gotten a transplant from a half-match donor, and the fact that she doesn't need any blood transfusions, she hasn't gotten a single blood transfusion for the last 4 months, and she's making all blood cells on her own, I would say that certainly is a success for her right now. Some individuals may develop complications of transplant, but if without a transplant, their life expectancy was 0 or close to that, and now they are surviving with some complications of transplant, again, they may say that that's a success for them. So I think success is like beauty, it's in the eyes of the beholder. Of course, if somebody passes due to complications of transplant or develops horrible complications of transplant, that their quality of life is now worse than what it was before, all of us would agree that that's not success. But I think if they don't need blood transfusions anymore, and either they have no side effects of transplant or they have mild side effects of transplant, I think that's a reasonable success. Does that answer your question?
Okay.
Something, okay.
Any other questions?
So what's the process of ensuring that one of the donor is a suitable donor?
That's a great question. Thank you for asking that. I didn't actually cover that in my talk. So what qualifies a suitable donor? So of course, when we're trying to do a transplant, we are trying to save a life of the patient. But at the same time, when we go to medical school, we're all taught first do no harm. And so one of the first tenets is when you're trying to collect cells from the donor, just make sure that you don't do any harm to the donor, right? So if the donor has any health conditions, they may have a heart condition, they may have diabetes, which is uncontrolled, they may have some other immune issues, which could put their health at risk if we try to do the transplant. If the donor has any of those, then that's not a suitable donor. That we will not use a donor if the process of collection of hematopoietic stem cells would put that donor at risk of any way and sort. Another thing is when we are collecting the graft and planning to put that into a recipient, we also want to make sure that we don't transfer any infections or any diseases from the donor to the recipient. So again, if the donor has any infectious complications, which could be transmitted through blood, we would not use one of those donors. So there are a number of diseases which get transmitted from blood transfusions, and if the donor has any of those, we would not use that donor. And then there are certain diseases that we can't test for, or there are certain areas of the world where those diseases are more prevalent. And so if you come from an area where malaria is very common, we generally tend to avoid donors from those areas unless it's an emergency. And then lastly, if somebody is pregnant, we try not to use pregnant women as a donor because it could affect the fetus that's growing within them. And so all these things, having a chronic health condition like diabetes or heart condition, having an infection which gets transmitted through blood, coming from an area where some of these infections are very common, like malaria, or being pregnant would disqualify or make a donor unsuitable.
We do have a couple online that to get to. So one is if a transplant fails, can you have another one? Also, if your DNA is changed through having a transplant, does it potentially change your moods or even personality?
So the question, that's a good question. So let me answer the first part first. Can you have a second transplant if your first transplant fails? And the answer to that is absolutely yes. You've got nothing to lose there because you weren't, especially for aplastic anemia, you weren't making blood cells before. We tried to do a transplant. Your T cells got rid of the transplant. You still don't make any blood, so go for another transplant. And we have certainly done quite a few of those. We can sometimes use the same donor. Sometimes we mix things up a little bit. We try to use another donor if another is available. And what we definitely do when we do the transplant the second time is we intensify the conditioning regimen. So we try and give a higher dose of chemotherapy or radiation to make sure that that damn T cell, which is causing all the problem, goes away for good this time. And so we can definitely do a second transplant. Now, to answer your second question, I think it's a little bit harder. And so can your mood and your emotions and your personality change after getting a transplant? I can tell you that my personality has certainly changed after I became a transplanter. Now, but jokes apart, the DNA that we are changing or the cells that we are changing, we are only changing those cells which make blood cells. So the rest of the cells in your body are still yours. The only thing that we changed are your blood cells. So you still have the same brain, the same heart, the same lungs, liver, kidneys, skin, everything is else the same. So technically it shouldn't change your behavior and your personality, but transplant is a life-changing process. I mean, I showed you that timeline. It can take several months and you will be stuck in a hospital for 4 to 5 weeks. And for some individuals, that in itself might be a life-transforming process. Some may start becoming more spiritual after that. Some may completely lose their spirituality after that, or other things might happen. I think those things are definitely concerning. So we make sure that anybody who's going for a transplant meets with a psychologist, because it is a very intensive process, not just on the patient, but also the patient's family. And so we want to make sure that patients are generally prepared for what's coming for them, or what's coming to them. And so there could be psychologically changes which are affected by just the process of going through it, but not necessarily the genetic changes.
Another one says, with the presence of past few years, has it had an effect on transplantation as a choice for therapy for the patient? Are doctors more hesitant to refer for BMT?
That's a wonderful question. So the question is, because of COVID over the last 2 years, have we changed how we approach patients? So yes and no. When COVID started initially, and as you all remember, I'm sure you've seen enough pictures and videos of hospitals being full. There is that famous picture of New York hospitals being so full that a Navy ship had to be brought in there. So when the hospitals were that full initially in the early part of the pandemic, we just didn't have the capacity to do transplants. So at that time, a number of transplants were delayed or canceled. But as we have gotten better and the hospitals are now not as full and we have more resources, the transplant numbers have generally come back up to pre-pandemic levels. We are now doing just as many transplants as we were doing before. And so there was a phase early in transplant where I think physicians were more hesitant to recommend transplant, not because you didn't need it, just because there weren't enough beds available. But now I think that has changed. Now, actually, the pandemic in some ways has been a blessing in disguise, a silver lining, because we have changed how we do transplants now. So as I mentioned earlier, the unrelated donors that are registered in the registries, they may be in another country, and sometimes, and these cells have to be flown in fresh, sometimes within 24 hours or less. And so we know now that flights get canceled, and if somebody needs an urgent transplant and a flight got canceled and it took longer than 24 hours, those cells, those precious cells will go bad. So now what we've started doing is we have actually figured out ways during the pandemic that we would freeze the cells and then fly them. And so in some ways, pandemic has also helped us become more nimble and actually change how we do transplant or our procedures so that we could make them safer in certain ways.
I know CAR T is fairly new, but is that an option for aplastic anemia?
So the question is CAR T therapy an option for aplastic anemia? And the short answer is no. CAR T cells are type of immunotherapy which is used for getting rid of bad cells. And the bad cells generally are leukemia cells or certain types of tumor cells. And so CAR T cells are actually a type of lymphocytes similar to the lymphocytes which kill our stem cells in aplastic anemia. And so CAR T cell therapy, unfortunately, does not fix the problem. Because the problem in aplastic anemia is people just don't have any stem cells left. The factories that make blood cells are gone. And so we have to replace the factory. And for that reason, bone marrow transplant is the only option right now. Now, if somebody were to develop leukemia because of a complication of their aplastic anemia, certainly for leukemia, there are CAR T cells now available, but they're not first line. So they wouldn't be used upfront in an individual who develops leukemia after aplastic anemia.
We do have a couple more online. So if a patient is relapsing, how does a family and medical team decide between another treatment, ATG or transplant?
That's again a good question. I think it depends on the individual. So people generally tend to look at how quickly did they respond early on. If they responded fairly quickly, sometimes maybe trying that same immunosuppressive therapy or using a different immunosuppressive therapy and going higher on the dose might be helpful. But if it already took like a very long time, if it took 9 months to respond previously, then I think people would argue, let's just go to transplant. Again, it also depends upon whether you have a donor available or not. If you have a donor, I think when you relapse from immunosuppressive therapy, most physicians would recommend you to go to transplant. But if you don't have a donor, then or you don't have a well-matched donor and you have to choose between a half-matched donor or a second course of immunosuppressive therapy, people can choose either or.
What is the most common form of GVHD seen in kids?
The most common type of GVHD, so we see skin, gut, and liver. That's the most common type of GVHD which is seen shortly after transplant. I'd say skin is a little bit more common. And most of the patients that I see who develop skin GVHD develop a little bit of rash, and we can control that by giving them medications and the rash goes away. I think a little bit more than that, children also develop some amount of diarrhea, which again is quite common after transplant, but then we treat it and it goes away. Liver is definitely the least of the common GVHDs that we see.
I think we may have one more. Does having a transplant for aplastic anemia prevent development of PNH? My son was not diagnosed with PNH prior to his transplant.
So yes, actually, transplant is an indication for treatment of PNH also. For PNH that is not controlled, actually PNH associated with aplastic anemia. Transplant is actually recommended for those individuals because those who actually have a PNH, they usually don't respond to immunosuppressive therapy. So in those individuals, we generally do tend to recommend that they should undergo transplantation if a donor is available.
Actually, one that came in at the time for it. My son was just diagnosed with aplastic anemia and does not require treatment at this time. How will we know when treatment is needed?
So I would say talk to your physician about that. By definition, if he was diagnosed with aplastic anemia, then he probably needs some sort of treatment. But again, I don't know the details and I can't comment on specific situation in this. But talk to your physician and hopefully they should be able to answer.
Well, thank you so much for your really great presentation, Dr. Sharma. Thank you for sharing your time and expertise with us. If you would like to watch this session again at a later time, it will be available on the conference platform in the next hour by accessing the session and clicking on replay or by navigating the on-demand tab in the platform. If we were not able to answer your question today, you can send it to us at any time in 3 ways. First, send an email to help@amds.org. Second, call the AMDSIF helpline at 800-747-2820 extension 2. Third, submit a question on our Facebook page, www.facebook.com/AMDS. If you're watching online, please take a few minutes to complete the session survey. Your input is important to us and helps us plan for a future educational program. On behalf of the Aplastic Anemia and MDS International Foundation, thank you for joining us today and making us your resource of choice for information on bone marrow failure diseases. The AMDSIF Medical Advisory Board and team are here to help you and your family as we have for the past 39 years. This concludes the session.